the risk to die in surgery, in anesthesia, in Rwanda are quite very low now. So I was saying that probably this coming from a historical background because surgery was not safe for long, and people were dying, and the mortality rate around surgery in the beginning of surgery was around 100%. And sometimes people joked it was 200%. The patient was dying and the surgeon also, because you can.
Good afternoon. Thank you so much, everyone, for tuning in at the Voices podcast. My name is Arafat. Today we have a special guest. We have a special voice in the studio. Today we have Professor Faustin Ntirenganya, and he's a professor of cosmetic and reconstructive surgery at the University Teaching Hospital of Kigali. He is a lecturer at the University of Rwanda, and of course, he is the head of surgery at the University of Rwanda in Rwanda. And of course, he heads the Rwanda Surgical Society.
Yes.
Rwanda Surgical Society.
Rwanda Surgical
You are the
Society.
president of the Rwanda Surgical Society.
Yes.
Doctor, good afternoon.
Good afternoon.
Thank you so much for taking your time to come to our podcast.
Yeah, thank you. The pleasure is for me.
I've been looking for you for a while, but finally I've got you here. Thank you so much. We don't take it for granted. I know you people have a very, very busy day, and it's hard to get you, but finally today I have you here in our studio. And my first question would be like, you're one of Rwanda's most experienced surgeons. And I would love to know, can you take us through your specialization, where it starts from to where you are today?
Thank you. As you put it in the introductions, I'm a professor of plastic and reconstructive surgery. That is a surgical specialty dealing with restoring forms and function. And broader to that, we also deal with the cosmetic part of it, which is not as big as the first ones. So in plastics, we have congenital anomalies first, those babies who are born by different malformations. And then we do trauma and cancers. So those traumatic patients who need to reconstruct by replacing some parts of the body who are damaged through accident and etc. We also help in reconstructing post-cancer surgeries. And on top of that, we also do some cosmetic surgeries. It means reshaping or changing some parts of the body. So that is how big the scope of plastic and reconstructive surgery. We do that in general, but for me, I subspecialized in breast, so oncoplastic surgery. That is my small area of expertise.
In plastic surgery?
So within plastic surgery.
In plastic surgery, you're mostly focused on breasts?
Yes.
I mean, breast reduction, breast increase.
That.
And also breast cancer treatment?
Breast cancer treatment, breast reduction, oncoplastic breast conserving surgery.
So in the reconstructive surgery, what are some of the most frequent cases do you treat?
In the reconstructive part, so me as a breast oncoplastic surgeon, so I have, if I look into my patient log, majority of them are breast cancer patients. But further to that, reconstructive wise, we deal much more with complications of burns. So I find that post-burn contractures are representing a huge chunk of what we do. And then other traumatic injuries, so from open fractures to hand injuries. So if I put it that way, that will represent fairly what I do.
You've talked about breast cancer treatment. I mean, can you take us through that? How is breast cancer treatment so far in Rwanda? Where do we come from and where are we today? Because I'm sure it comes from somewhere and we're now somewhere.
Yeah, breast cancer is particularly interesting to me because basically that is where my PhD is actually. So I did my PhD in breast cancer. Uh, it is the first cancer in this country. So I don't know if people know that. So it represents the most frequent cancer in Rwanda. And globally, it's the most frequent cancer in women. And the first cancer-related mortality and morbidity is from the breast cancer. So in Rwanda, the particularity that I see is that we have breast cancer in relatively young women. So generally, breast cancer is supposed to be a cancer of older women, so 60s, 70s, but ours are around 30, 40, 50s,
Really?
which make them very young. And it poses a serious issue in terms of coordinating and outcomes because it may have some particularities in terms of some molecular subtypes of breast cancer that we may have, which are not necessarily in other countries. So that's probably another debate.
What did you discover about that? Maybe simply about that.
Oh,
What was
that's
the discovery?
quite very interesting. So because my PhD was actually on that premenopausal, what we call premenopausal breast cancers. This is a cancer that is happening when people are still having their menses. So it means when ladies are still young. And it is quite very representative. If we remember well the numbers, it was around 56%. So of all the patients that we were having in my cohort. So, and the majority of them, around 26%, was having a very bad kind of tumor that we call triple negative. This is a tumor who is positive to estrogen, positive to progesterone, and positive to an oncogen called HER2/neu. So this is one of the bad tumors which are very aggressive and rapidly growing. So, but there were also other subtypes of what we call bad prognosis. So those are HER2/neu, what we call HER2/neu enriched, and other similar tumors, which if you put together all the subtypes of bad prognosis, you come closer to 50% of the patient, which probably explain why we have breast cancers in young women. So it means we have to go further and test the genetic part of the tumors, so that we understand if we don't have those kind of mutations that will predict our ladies to have breast cancer at
So
any
like
age.
if we are informing a young lady who is maybe 20 years to 50 years, who want to know why they are considered to be the ones with higher percentage of getting breast cancer, what would you tell this person? What is the main cause that you've discovered in your research or that you see out from the patients that you treat that might be the cause?
Yes. Actually, as you get your breast cancer younger, so the likelihood of having a genetic mutation is high. It means if you are in your 20s, early 30s, so the probability of having what we call BRCA1 or BRCA2 mutations are very high. So those are kind of cancers who are transmitted within families. So that's the chunk of, they represent overall around 5 to 10% of all breast cancers. And I suspect that is the kind of we do have. But if you look at the risk factors in general, there is no risk factor outstanding. In my studies, I only found that obesity in early childhood, it means when you see when you are obese around 17, 18, this is a big risk for having a premenopausal cancer. And that is actually one of the there are a few papers out who have the same findings, but it was clear in my cohort that those ladies who have
Who are obese?
who have been obese actually when they were young. They were not necessarily obese the time of breast cancer. But if you go back into their history, you trust an obesity or overweight, what was classifying as obesity or overweight around the puberty. So that's a big risk that people should continue exploring and see if it stays significant.
Oh, wow. So for a girl, maybe in her maybe 10, 15 to 20 years, if she was obese or overweight,
Yes, that has been significant in my findings.
that this person has a higher percentage of facing breast cancer
At young age,
before menopause.
before menopause.
Wow, that's really big. That's very big. So people should know that being obese, or if your child is obese or overweight while they are young, there might be problems ahead that might face,
Yeah, truly.
including even breast cancer.
Yes, and it's a message probably to parents and to others who like when kids are obese. And it tend to be tendency like, when you are good, when you have a very wealthy family, then you want to show that by maybe turning your kids into obese ones. So that's a very big mistake. So I would advise that they don't do that. They keep the right weight, at least at the around 25 BMI, so body mass index, around 23, 24. But if you go at 30, 35, that's a very big risk.
So, doctor, you've been doing this I call it business, but this profession for a while, and you've really treated so many people. What is it are you proud of when it comes to treating breast cancer in Rwanda? Since the time maybe you started treating it in Rwanda and up to now, what is new in breast cancer treatment? What are some of the new things that are you proud of today?
Yeah, I think breast cancer is in among those few cancers, because people just say cancer and they think it's one disease when it is not. It is a cancer is a multiple diseases, 300, 400 of them. But even breast cancer is not one disease. For now we have like 5 subtypes which behave differently on progression, on treatments. We do have subtypes. So now in Rwanda, I think and I see that breast cancer is among those few cancers that we treat with a very good outcomes and with the intentions to cure. So when we have intention to cure, it means we treat and you are cured and you continue life like it was before. So we have now all what it takes in terms of breast cancer treatment. From the diagnosis, when you see how people can access mammographies, ultrasonographies, pathology services, those are the foundation. Those are the key, because you cannot just look at someone and say you have breast cancer. You have to have radiology, you have to have pathology in place to make sure that the diagnosis is accurate. On top of that, people need surgery. So actually all patients with breast cancer should be operated at a certain stage in their treatment. So far we have surgeons who are doing breast surgeries. They are not many now. But
how many so far do we have?
So far we do have now in the country, as I speak, 3.
Who can do breast surgery?
Who are specialized breast surgeons, but others can also do some breast surgeries. But at specialty level, we can say 3. But the beauty is that we have now started training locally the breast surgeons through a fellowship that actually started last month. So our first fellows are now on board. So we have 3 fellows who are learning now at specialty level how to do and how to deal with breast cancer. So surgery-wise, we are okay. So we think we can provide from simple surgeries to much more complex surgeries. It means from lumpectomies to breast conserving surgeries, oncoplastic surgeries, and even breast reconstruction. So we can provide all that here. So, but that is not enough, because breast cancer therapies is a multidisciplinary disease. So we need our oncology colleagues from medical and radiation. So medical wise, we have a good number of medical oncologists now who are very conversant with the breast cancer therapies. So from standard chemotherapy to hormonal therapy, molecular target therapies, all that can be delivered here, and we have them. So radiation wise, I feel that is where we may look at improving. We have a radiotherapy center and the radiation machines in Rwanda Cancer Center. But it is only one center for all the country. And the people can access it, but I found that is not timely. So there is a room to improve time-wise so that we can, everyone who needs it, get it when it needs it. So it means we may need probably to have other radiotherapy centers, maybe 2 or 3 or 4 others additional. But as we have only one now, it's a good move, it's a good progress, but we still have to improve because people needing radiotherapy are quite many in Rwanda. So in summary, if you see all those 3 pillars of breast cancer management means surgery, radiation, and medical therapies, we are well grounded and we can provide up to 90-100% of what the patient may need. So that's why I say I saw it progressing. When I came here in Rwanda from the training, maybe 11 years ago, so it was not that way because we didn't have the radiotherapy that time. Medicines were not available, and few available were probably very expensive. So, but now the mutual is covering them. We can have chemotherapy in our hospitals. So the radiotherapy center is there. Surgeons are increasing. So we are on a very good track.
But let's assume, let's speak to the breast cancer patient right now who's been diagnosed with breast cancer maybe today or last week, and is wondering how he's going to go through this process. First, from finances to the theater and getting out of the theater. What should someone expect? What should that patient expect right now? From the diagnosis, you've received the information that you have breast cancer. From that moment to the cure, to the recovery, what should this person expect?
Yes. What I'm going to tell you is what I tell my patient actually. Anytime that I diagnose a breast cancer patient for the first time, so I tell her or him, because men also can have breast cancer. So, but the majority are women. So, but let's use women. So I tell her that this is a very big diagnosis. So it's a bad news that I tell you that you have a breast cancer. But I also tell her that in this bad news, I also have a good news for you. So the good news is that breast cancer is a curable disease. So that being said, we take it now as any other disease, which is very heavy, and we'll draw the pathway for you, and we start discussing. So I tell her, so we can treat with the curative intention breast cancer patients up to stage 4. So stage 4 means those patients who don't have metastasis. It means when the tumor
has not spread.
It was not spread.
Has not spread already?
Yes. When it has not spread already through from the breast to the lungs to the bones to the liver, when it is not like that, you can expect to be cured.
So from level 4 going down, level 4, level
3 going down,
you can be cured.
You can be cured. Not level, stage 3.
Oh yes, stage 3.
Stage 3 going down, you can be cured. So now, if you will understand that if you come
to see me, but if they tell you are stage 4, don't expect to be cured anywhere in the world. So you can live as long as possible, but one day
breast cancer will take you. So it's for now in medicine, we don't have cure for stage 4 patients. So
All over the world.
All over the world. So that's why we tell people you better consult early, so that you have the chance to be diagnosed at early stages. Stage 1, very easy. Stage 2, relatively easy. Stage 3 becomes complex. So it means why I'm going in details. It means that you don't need the same thing every time. And the 2 patients will not need the same thing. That's why you have to customize the needs and the pathways and the discussion to each of every patient. Not only the stage, as I am saying, but also the tumor, because I was saying in the beginning, the breast cancer can be multiple. So multiple types. So there are those who are very simple, easygoing, slow progressing, what we call luminal A. The others who are terrible, very aggressive, like a triple
really fast.
Yes, like a triple negative. So that's why when patients are discussing outside the door of the doctor, they may think, oh, I received this, you didn't. Maybe I should tell the doctor to give me what you are getting because I see you are doing well. No.
It depends on the kind of cancer you have.
It depends on what kind of cancer you have. So that's why I tell her, so the good news is that it's curable. However, we go into those details, saying, this is your stage, the expectation is this one, this is your type, the expectation is this one. So, and then we put everything together, and then we draw a roadmap, saying you're probably going to start with medicine. If the tumor or the cancer is advanced, what we call locally advanced, the studies now show that there is benefits to start with the medication.
So the locally advanced cancer is one that is still in one position.
So the locally advanced, it means you have a tumor in the breast,
but has not spread into other parts. It
has small satellite lymph nodes in the axilla, but it has not yet gone to the bones, to the brain, to the lung. It is locally advanced.
But so that one is manageable.
That one is manageable. Yes. No, so that one is manageable. It is curable if we go and we get everything that we need. So that everything is where it's going to be discussed, and everything is not enough. The timing of it is also matters. So that's why we say pathways matters. If we say you have to be operated, and then 1 month later you get this, like a treatment, maybe chemotherapy. After 6 months you get radiotherapy. It should be that way. If we say, oh, for these ones, you better downstage. Downstaging, it means you start with the medication, take medicine, the tumor shrinks a little bit, becomes as a lower stage, then we operate, and then you do radiotherapy. It should be that way. So the pathways and the sequence of treatments are not the same to all patients. So, but without probably going into the details of technicalities, so your doctor or your oncologist or your surgeons should bring this into a meeting of other doctors so that they agree on who comes when, so that they design for you the roadmap, saying, okay, you are starting with this, second that one, last this one, and we are going to follow you this way. So normally we take up to 5 years to declare that you are free from breast cancer. So before 5 years, no one can tell.
So a breast cancer patient, once you are diagnosed with breast cancer, expect to be informed whether you are free from breast cancer after 5 years.
Yes.
What could be the cost? If you can do the summation, assume, what could be the cost of someone to be treated for that period of 5 years?
So if maybe
they don't have
let's take the most frequent probably subtypes. Let's assume the easy one. The easy one is going to be a lumino A stage 1 tumor. So, and you get your surgery, and the surgery is just a lumpectomy, and maybe an axillary sampling, and then you get your chemotherapy, and then you have the radiotherapy. So the full package. So surgery is not actually, I find not to be expensive because the insurances are covering it. So probably, let's say
for someone who has Mutuelle de Santé.
You have Mutuelle de Santé, you may maybe pay $10,000 for everything.
$10,000?
No, Rwandan franc.
I mean, for the 5 years period.
Because surgery happens once.
It happens once,
yes,
but there's so many other things.
I'm
chemotherapy.
going to make a summation.
Okay.
So medicine, you get your chemotherapy, and let's say probably you may end up having 50,000, and then you go for radiotherapy. Radiotherapy is the most expensive for now.
Because it's not covered under the Mutuelle?
No, it is, but the sessions are many. So they do around 26 sessions
in 5 years.
No, in 6 weeks.
Oh,
yes,
because
they go there 5 days a week for 5 to 6 weeks. So that one, it may be challenging for some families. So, and then if you see what someone who is paying everything from out of the pocket, probably radiotherapy may cost 2 million here in Rwanda. So if you go to Kenya, you may have 4 or 5
for radiotherapy.
So you go to India, it may be around 7,000, that kind of money. So, but here in Rwanda, it's around between 2 million and 3.
For someone with Mutuelle de Santé? No,
for
a private.
For a private guy. Okay. But for a Mutuelle de Santé, it may be maybe 200,000. 200,000. Yes, between 100 and 200,000. So if you sum all of that from the out of pocket, maybe if you have an insurance, you can account around 200, 250. So that everything is covered for all over the 5 years. Because in the longer treatment actually is cheap. Because those who are taking a longer treatment are those who are positive to hormones, and they take hormonotherapy for 5 to 10 years. And it's just one small tablet every day. And those on Mutuelle, they may be 100 francs. So those are not so expensive.
So we should assume that for someone who is a private patient, has no single insurance, not Mutuelle, not Rama, not any insurance, maybe the cost can be like $10,000.
Yes, I think
in Rwanda, if you come to do the treatment in Rwanda,
if you
maybe
come
from all over the world,
it may be a little bit higher. So, but I may say probably 10 to 20. So to make people don't feel that it is cheaper. So actually, it is not. So, but with the system, with the insurances, it becomes very, very cheap, and people may think it is not expensive to the system. It is. So breast cancer therapies are expensive, but the mechanism around make them affordable, and that's the beauty of it. So, but if you pay everything from the pocket, you probably count 20,000.
Doctor, many people fear the operation room. You call it theater, and I remember we were talking, and you told me that we usually get on a motor every morning and go to work, go everywhere, and we feel like there's no risk, But someone is told to go to the theater for an operation that is going to maybe change their life, or maybe treat them or cure them. But people feel like, I'm scared. When you tell someone I'm going for an operation, they say, this one is gone now. Yeah. What would you say about that?
Yeah, that's true. Actually, that's one of what I don't understand. That people are not educated. That theaters are very low risk. We generally in surgery. I'm not talking about Rwanda. The perioperative mortality is 0.1. People don't consider the risk that they take outside there, and they think risks are in theater. We are very low risk. I'm not saying that theater is risk free. That's surgery, and surgery has some risk, but the risk to die in surgery, in anesthesia, in Rwanda are quite very low now. So I was saying that probably this coming from a historical background, because surgery was not safe for long, and people were dying, and the mortality rate around surgery in the beginning of surgery was around 100%. And sometimes people joked it was 200%. The patient was dying, and the surgeon also, because you can attract the patient disease. So protection was not good, monitoring was not good. But now, as we have very good monitors and machines, when someone is sleeping, we know the details. It's like I was saying, it's like aviation. When you have your flight from Kigali to London, the pilot is not seeing like you drive by the car. He's not seeing in front. He's looking at monitors, and have a lot of data, a lot of whatever telling him or her where he is, the situation ahead, predict all that. So we have the same in surgery. And sometimes I wish that people may be coming in theater when they are not sick, just to come and visit and have a look. And
but doctor, you are lying to me.
No, why?
I would love to come. Man.
Please come.
Seriously, I would love to come when... Is it okay to come when you are having a patient to operate on?
That one will be debatable, because when we have a patient to come to operate, it depends on which patient.
Maybe I want to see how the procedure yes. is in the theater. Like where do you start from, and how do you make the patients?
I'm inviting you. Come.
Wow.
So come, and probably you will tell the story better than me, because I'm not a storyteller, I'm just a surgeon. But I'm telling you that people come in theater when they have already that panic, because it's a closed space.
That's something I wanted really to ask you about. This speaks to everyone in the world, not just for anyone where we are now. How do you ensure that the panic that a patient has before they enter into a theater is reduced? How would you work around that? How would you prepare a patient for surgery?
That's a very good question, actually. And this is
how should a patient be prepared?
Patients are prepared multiple ways, and by multiple people. So we, as surgeons, we are the point of contact of every patient who comes to theater. So before seeing any other professional in theater, you have seen a surgeon. So our job and our role is to make sure that we explain what is the disease, and what are the options to treat, what are the risks, what are the advantages, all that. And we try to explain to you in the language you can understand how things will happen, and from A to Z. And now we say, okay, we are going to hand over to you to another professional, which we call anesthesiologist. That is the one who is going to give anesthesia to make you sleep and awake. So they also almost repeat the same thing, but add their touch around the drugs they are going to use, around the probable risk, the outcomes, all that. And then you go to the maybe a word to the nurses, which also will work around the same themes, but in their own language. Nurses insist much more on these interpersonal things, the families, how people what they can expect, where they are going to stay waiting for you, all that. And on top of this explanation, this is actually education. That's what I say. That can even happen now, before you get even sick, so that you know the processes, you know the risk. I feel if tomorrow I'm going to be operated, so some of that I know from my professional standpoint, but I will also need someone to probably customize that for my day of that day.
So the emotional touch.
The emotional touch. So now after that, you will now have the medication part. So what we call pre-medication. It means there is some drugs that people give you the day before or a few hours before surgery to relax you, to make sure that you don't have stress. So all those combined is what we call preoperative preparation. So it's that long period. So some may start days before, others the day before surgery, others the morning of surgery, based on where your schedule is. But preparation for me is not enough. It's like I tell you, look, we are going to travel to go through this river. So, and you see me for the first time. Even if I tell you I'm the best swimmer of all times, you will not trust me until you see me in the river. So that's probably, I feel, is the problem we have with the patient, because people are not coming in surgery every day. It's probably one life event, and that one life event, you want it to be perfect, and with the most experienced person around. And I agree with that. But sometimes,
because life lost cannot be repaired.
I know, but let's go back to my motorbike thing. Do you ever ask the license? Do you ever ask the driving license
of a motor rider,
to the motor rider or to the driver of
before
the bus?
you board it?
Before you board?
No.
Why?
I just trust them.
You just trust them?
I just trust them.
And
that's
then,
it.
surprisingly, people don't trust the medics. They trust less surgeons. Sometimes you even say, are you sure? Because sometimes there are even procedures that are so simple that can be done by very junior persons. But from that standpoint, that's why I say, okay, probably discussing about that may be important, and people starting being educated and know what happens and what are the risks probably may help to decide. Because it's very difficult. Sometimes I feel that we're asking them to decide when they don't have all what it takes. So we have not provided all the information necessary, and we're asking them to decide. And then they are like, that fear, when they wake up, I find when those patients that I operate multiple times, it is very easy to convince them the second time.
You are saying that we don't trust these guys. We don't trust motor people.
You trust border guys, drivers, better than you trust us.
Who have studied it and who have qualifications. But doctor, you know why? The motorbike, look at the motorbike. When I go on the motorbike, maybe I'm likely going to have an accident still and also land in the hospital with you. But the thing is, in the theater, I know you're going to cut my body in 2 pieces and land and go somewhere. Maybe you're going to operating me, you're going to cut, go somewhere deep inside my tummy and maybe pick some other things and then dive in and find what you want. So sincerely speaking, even myself, I've never had a chance to see inside myself. And how do you think I'm really going to be just easy like that and trust someone to dive into my tummy, you know?
I'm not saying that you have to be so easygoing, but, this is something really needing some degree of trust. And that's where the trust, you trust in multiple, trust should be at a multiple level. So you trust in the surgeon you have in front of you. You trust in the hospital he's working for, and you trust in the system which is certified that this guy knows what he should be doing. So because you don't improvise to be a surgeon, don't just wake up in the morning
And say I'm a surgeon.
and say I'm a surgeon, like you are opening a shop. No, these people pass through multiple trainings, a lot of time, a lot of processes, till one day people say we can trust you, you are safe. And that's probably where people should put emphasis, is to have a system that they can trust. Because if you just judge individuals, it will be very difficult for you, because at the end of the day, when you are sick, it becomes me and you. But the me and you should happen when all the checks has been done. Is like I was giving the analogy of the pilot. I have never asked if the pilot in Rwanda is good or not. Because I trusted
I'm
Rwanda.
not even sure whether he's qualified.
Sometimes you don't even know that there is a pilot inside. You just go in and you go. You have not even seen him. Have you ever seen one?
How many that go in the cockpit? I don't know what they call it.
So,
No one. How many? No.
Yeah, you just go in, but you trust the system. It's not by hazard or chance that this guy is sitting in Rwanda in a cockpit and you are going to fly together to London. So it is the same. All those systems happens in surgery and in theater. Those checkpoints. We even have what you call surgical safety checklist. Like we people do for the aviation. You check, so that someone can enter, so that you avoid maybe people can not be serious enough, that kind of stuff. But believe me, if we speak for Rwanda's theaters in Rwanda are safe, but there is a room for improvement for sure.
What are some of the things that you still see, like, because you are now the president of the Rwanda Association of Surgeons?
Yes.
And I believe there are so many things that you talk about in your association. What are some of the things, if they're not secrets, that you can share with us, that you still always tell them, A, B, C, D. I'm considering you to be their boss, but you tell them, A, B, C, D, we're not doing well. We should improve here and here. Where is that?
Yeah, I think I can maybe group that into two. There are those who are surgeons specific and based on our profession as surgeons, and there are others who are systemic issues. So if I can start by the surgeons, so I tell them, keep you updated. So you are not allowed to say, I don't know. Because if you decide to operate on someone, you should have all the accurate and the most recent knowledge and skills in that domain. So it's up to us to be updated and to keep us on learning. So this is what we call continuity in medical education. So we should continue learning. On top of that, I tell them, don't take things as granted. You have to be masters of the details. So in surgery, we are teams. But even if we are teams, we make one team. And that one team, naturally, the surgeon is the team leader there. So you are like the coordinator. So you have you as a surgeon. But what happens to a patient is not only surgery by like a technique. There are people who are giving anesthesia, there are others who are giving instruments, there are others who are counting. So a lot is happening, but you are coordinator. So you have to make sure that you have that sense of detail so that no one is neglecting anything. So keep awake, keep updated.
But doctor, sincerely speaking,
yes.
Before you proceed from there, you're talking about it and it makes me wonder and think a lot. Someone like you who is focused on a patient, on making sure that you go well in the procedures of operating, and you also have to focus on these other people surrounding you, that they don't make any mistake.
Yes.
That's a very big work.
That's a very big work. But there is a session.
A lot of work.
There's a session before surgery that we all pause and we go through the steps and we check everyone, saying, for you as a surgeon, what are your steps, and you tell everyone so that everyone knows what you are about to do. And then if someone has an issue, it should be raised that time. So if from the anesthesia aspect, they tell you how they are going to do their things, and you have not yet started. You are around the patient. So from the nursing, they tell you how everything is set from their side. So that's okay. You double check if everything is ready from the beginning. Now you start. So as we trained to do that job, so when you account an issue as you go, you are requested to tell the others what is the issue, why are you slowing, all that you share with the team. But at the end of the day, that's what I was saying. We have to trust each other. I'm not there to check if my anesthesiologist is giving the right dose or the right medication, because I trust that he or she has been trained to do so.
And we've been working together maybe for some time.
Even if we have not, he should do that because he or she is a professional. So I don't have to tell him or her, or I don't have to teach him or her how to do the job. Everyone there should have the right knowledge and skills to do what he's supposed to be doing. If it is that way, that you lose the patient. So that's why actually the effort is made before surgery. So effort in training people, effort in recruiting them, effort in keeping them updated so that you don't have those things. Because as you're putting it right, as you are operating, you cannot go and check the other one's jobs. So, but everyone is a professional and everyone is actually independently doing what he's supposed to be doing. But coordination doesn't mean you replace everyone. But it's like look at the engineers building houses. So they don't come necessarily to paint or to put a roof, but they know when the roof is well put, and they know when the paint is enough, and they tell the painter that's okay for the painting. So that's how coordination look like in surgery. So we do our job, but we are a team, like a football team. So you have those who are in defense. So they probably, as you are putting it right, we should have a coach sitting outside and looking at us and telling, oh, this one is the time to do this. But some surgeries do that.
That's what I'm saying. That's what I was trying to say, that because you have a lot of work to do as a head surgeon, and you are looking at a patient doing a lot of work there, and you need to pay attention to the details you told me about, that if you make a slight mistake on someone whose organ or body, that mistake cannot be easily reverted.
Yeah.
And you also have that role of checking whether every equipment, every machine is running the way it's supposed to be running. That's heavy work.
Yeah, it's a heavy work, but it's doable. So sometimes you don't feel how heavy it is. Because you have been trained to do so. It's like you ask those who are running the 400 meters in 10 seconds, how do they do it? They train, and at the end of the day, they make it. So that's the process. That's why actually the trainings are so long and ask to grab not only those technical proficiency, but also add some non-technical skills to make sure that you can coordinate a team, you can anticipate, you can lead, you can communicate better. So if you only have technical skills in a hand, if you can cut and suture, it doesn't make you a surgeon.
No.
So
you've recently in one of the conferences there was a surgeons conference that took place in Kigali, and you said that surgery is a life-saving intervention, but so many people still lack access to surgery, which is detrimental to their life. What do you think countries like Rwanda or even other African countries that still have limited surgeons can do? Or what are you doing at home that you believe that maybe in 10 years the number will be doubled?
Yes. Yeah, that's right. So surgery is essential for health services. And up to 30% of all diseases are actually amenable to surgery. They are diseases to be treated by surgery. So if you have 10 patients, so you know that 3 of them will need surgery. So now in a country like Rwanda of 14 million, so we expect around 700 procedures every year. So unfortunately, as we speak now, we are around 240 something.
So you said in Rwanda we usually need 700
Yes.
procedures
Yes.
every year
Every year.
for surgery.
For surgery.
And this is expected to be done by how many surgeries? Specialized surgeons
for the
we have.
specialist surgeons, we expect to be having 1,400.
So far, how many do we have?
162.
162 surgeons.
Yes.
And you hope to have
Around 1,400.
in how many years?
So now, those are the ones we need.
Those are the ones we need.
So
we need 1,700?
1,400.
We need 1,400. And we only have 1,162.
Yes. So
how are you planning to raise that number?
So
that's a big number.
That's what probably are going. We should be spending time discussing that. So because this is for me the most important piece of the business. So if you take into roughly numbers, we are 10 times less than what we should be doing or having. So now we have to find a way of catching up and closing that gap. So if we continue the rhythm we have now, the projections are showing that we may need around 200 years to get the numbers we need.
If we go with this,
if we go with the normal way of how we are doing it now, just treat. So now we have to find another way of doing it. So some of the initiative that the country has started is the 4x4 strategy that you heard about. So that will be not enough for surgery. So if we multiply by 4, we will have like 500.
It's 160 times 4. 162 times 4.
That's so around 600, 400. Yes. So I actually around it about 700. So this strategy may take us to 700. But the main issue that people don't put into the consideration, to make a surgeon, you need time. The minimum is 4 years. From a medical school, not from the beginning. So if you take someone who have already did 6 years of medicine, you add minimum 4 years to have him or her as a general surgeon. But if you want a subspecialist, then you add additional 2-3 years. So you may need like 5 years in an average to make the surgeon you need.
For specialty.
For
someone to become a specialist.
Yes, you need 5 years.
Additional to 6.
Additional to 6. So now, in those 11 years from now, the population of Rwanda will probably be the 2 times the one we have now.
Will be about 20 something.
Yes. So that's why you have to make really very big projection and start very big. So it will start from the undergraduate. Because you cannot have surgeons when you don't have general people.
Of course, you cannot skip that point. Yeah.
You can't. So you are going to start by increasing the numbers in undergraduate, then so that we can have a pool where we are going to get those one we are going to specialize. And then that's the move which has started so far.
But seriously, can specialization be reduced? I mean, can it be... I don't know how I wanted to use another word, but let me just try to see. Can you reduce 5 years maybe to 2 years, and will that quality be assured?
No, that's why I have not yet completed my because only making specialists will not make it unless people understand that you don't use a machine gun to kill a fly. So in surgery, from some circumcision to heart transplant, there is a range of things. So everyone needing to be operated, you don't necessarily to have a subspecialist operating on you. Even those general people that I'm mentioning, those from general medicine, they have also a contribution in surgical volumes. They can operate on people.
Minor operations.
Yes, minor, intermediate, because you can extend. That's what we call task sharing. Because we don't need to, that everyone needing an operation will come on a subspecialist to be a hernia repair. If you can do it without that, that's much better. So that's why I say the surgical providers, the number should be bigger than the number of surgeons. Probably there will be some what I can call procedure specific people. Instead of being a surgeon, it means you have a full, how can I put it? You have a full package. So that's what I call a surgeon. Someone who has a full package, who can operate.
Who has specialized in surgery and has accreditation, everything.
That's what I call a full package from A to Z. But I think for a country like ours, as the number you are seeing, if we really need to get to everyone who needs surgical care, we need to tweak it, like to make sure that we probably going to have some people who are going to be only doing this procedure and they do it alone because they cannot have the full package because they have not been through the training as long as that. And then we may increase the numbers and decrease the complications because people are not like taking a lot of risk for them to be operating everywhere, everything. So that is one strategy. But the most important piece is that we are going to go quick and try to multiply the numbers. It is beauty when you have one surgeon, because when you have one, you can make a second. Every surgeon is becoming a teacher, and every theater is becoming a class, and every patient is becoming opportunity to learn. And then if we do that all over the country, that we probably going to take fewer years than the other 200 I was mentioning to reach there. Certainly it is not 4, maybe 10, maybe 15, we may be there. But in 4 years now, if we can at least target to multiply by 4 the ones we have, it means from 160 to 700, that would be very good.
A good number. That would be a good number. Yeah. So if I've understood you very well, you're saying that, let's say we have a surgeon who has a full package, who is a full surgeon, but we can have also the general practitioners have the skills or given skills by you, the full surgeons, to help you share the task.
That's what I'm meaning.
So that if there is a case that does not require a full surgeon to do, they can take on and do it. Sure. Or even call you and give them guidelines. Yes. For as long as you've given them
I put it simply that way. Surgery is not different from other medical specialties. Let's take medicine, internal medicine or pediatrics. So if GPs can treat malaria, okay, no one complains that, no, I got a GP and I was treated for malaria. Actually, even a GP I feel that a nurse or some community health worker does that for malaria. Why we don't have similar things for surgery? It's because people actually think surgery is so complex, so expensive, so risky that no one can come in. And actually that is that change of mindset that we think it should change the things. So even community health workers can do something in surgery. For example, why do you want to take your bus from Cyangugu to Seashka to see me, just me to tell you are doing well?
They can call you.
You can call me, you can video whatever, you can go even to a lower level of cadre who can tell you, look, I don't know very well surgery, but what I see, you are healing. Because I was saying like post-operative follow-up. You have been operated. Because the surgery, that's the
And actually,
issue.
boarding a bus would cause you more trouble.
Yes, you have been operated. Then you go, you treated, the wound is healing. But you have to come to see me so that I assure you that you are doing well, that you are healing well. So we have to bring in technology. You have to bring in telemedicine so that there are some things that you don't necessarily to come to see me so that I tell you are doing well. So that we reserve those few that we have where they are really maximally needed. And we avoid to misuse them.
So, doctor, you're one of the people that have said that quantity should not overshadow quality.
Yeah.
And you've really stressed this so many times. And of course, you're the one telling me that we want to have at least every practitioner have access to surgery and do surgery. Going back to the students that you're training now at the University of Rwanda, how are you ensuring that these students adhere to ethics and high level of safety to the patients they go to treat, or after they've trained, how do you do the monitoring, especially in the residence?
So I will put it this way. So in surgery we have that issue that the best you can be, you will never operate on yourself.
That's very key.
So even a simple hernia repair, even if you get appendicitis, me as a senior surgeon, I will never take out my appendix.
I like that.
So now, it becomes actually a moral obligation.
That what you give now, you should expect to get the same next time when in case it's you.
Because you have no options. So I know one day we need to be operated for one or I don't know what. But when I'm going to sleep, I would wish that I see you coming to operate on me and I say, oh, that guy, that is the other guy trained, he knows what to do. But imagine that the same scenario, I saw you coming and I know that you don't know. So what will happen? So then that's why I say there is no debate. There is no debate. We don't have that luxury to say we can produce surgeons who cannot operate. No, that is not an option. And that's why I say this run over the numbers we should to do, because quality is good, but sometimes it is not enough. It is not equality when it is not accessible. So you don't have any quality because accessibility is not there. So it becomes quality when people can have access to it. Now, so we think that as we increase the numbers, we also have to make sure that we don't lose anything around the quality of it. So how that is going to happen? People may think that is controversy, and it is actually self-excluding. As you increase the numbers, definitely you draw in the quality. But we have to understand the surgery and think this way. Surgeons are made by two things. One is the volume. How many patients do you operate? Because I always say you cannot pretend to be teaching people how to swim when you don't have a swimming pool. So you can bring them in the room, you discuss swimming, but those guys will never jump in the water and start swimming unless you have a swimming pool, and they go in the swimming pool, they try, and one day they become good. That is how surgery is learned. So we need volumes, and the volumes are the number of patients we operate. So strategy number one, if you want to increase the numbers without losing in the quality, you have to increase the volume. So that's how it becomes a vicious cycle. So now, as we speak now, we think that we are going to be increasing like a mushroom. So now maybe the ad of today is going to be little, the ad of tomorrow bigger, and then the next one be very big. Because if you have one surgeon, you can train 2 surgeons. If you have 3, you train 6. If you have 6, you train 18. If you have 18, you train 64. It becomes exponential. So that's how it's going to happen. So it will take some time, but we have to be there in the system helping to control that the quality is not jeopardized. But coming to your first question, saying, oh, look, it's not because he's a general practitioner that he's not doing well. No, it's all about the competence that one get. So we can teach anyone to operate. So what makes surgery training longer is because you learn to do a lot. But if you learn to do a small piece of it, then you master that piece and you do it well, you are safe. I will trust you with my hernia. But I will not trust you with my brain tumor, because I will probably need someone who has another kind of training.
Specialization in this.
Yes. So we are going to build that like a pyramid and make sure that on top of it there are those few very, very specialized surgeons. On the bottom of it there are those who are broader and who can do multiple things.
Yes. So as someone involved in shaping Rwanda's surgical, policies, how are you dealing with AI? How are you trying to involve AI and innovation in surgery in Rwanda? Because, and of course, telemedicine to some countries is nowadays is done even in surgery. You find that someone is over that side and is operating on someone in Kigali. How are you going into that?
I think that is actually what I call equalizer. So technology innovations are the only way which can help us to move quick and join the others who are probably advanced than us. So 2 things. As you are fewer, you have to create alternative ways of reaching to the maximum. You have to multiply yourself. You have to duplicate, triplicate, or quadruple yourself. So now, that's where things like telemedicine becomes very interesting. So if I have to sit in a room like this, and I have 5, 10 GPs, as you were saying, that I'm mentoring or supervising, that I share cases, that I discuss with this. Because when we say surgery, people just understand just going in the theater and cutting. No, surgery is a big thing. So it started before, just the time to make decisions, to make diagnosis. It continues how to prepare patients. During surgery, after, you have to follow up your patient. You have to review. You have to have follow-up plans. All that, if I can probably, if I'm needed only for intra-op, and I focus on intra-op, that's good for me, because it will free the other piece, and other people are taking off. And then we can share that, discuss patient over telemedicine. Even we can help and guide people operating that way. AI. In surgery, some people think surgery is very conservative, but we are much more in technological dependent than any other field in medicine. So we have already started using AI in what we do, but now AI is helping us to be quicker, to diagnose better, to have the very good differential diagnosis. But most importantly, in some technological-based surgeries, robotic, minimal invasive, the image, because sometimes we operate just looking at the image. We don't have like a direct contact with the patient body. We're looking at the screens. So those technology AI-enhanced images are becoming much better. But it is not today. that AI is going to replace a surgeon. So even if you may have all the technological whatever you need, you will need a surgeon somewhere behind to drive it and to make its use. So that's how we are coping with the technologies. So, but I feel that those who are coming after us are much better than us. If I see my resident, how they do what I should be doing, let's say research. If I tell them go and do a literature review, they just go in 10 minutes, they come back with a very summarized, updated on something. So knowledge is going to be very easily accessible, but now the other time is going to be spent on skills acquisition. So it means if we really take advantage of the technology and this new moves, we are going to be much better and much smarter and much quicker as surgeons.
Do we have new innovations so far in Rwanda?
Yes,
in
many,
surgery that
many,
you can
many.
mention to us that maybe some people don't know, or new diagnostic tools that we have in the country that are helping you more than others that you used to have before?
So, sometimes what I call innovation may not sound innovation to others.
No.
But we have a lot. We have a lot. So innovation to me is something new. So new in its concept, new in its application. So surgical wise, we are. I don't know if people know that now in the hospital at King Faisal we have a microscopic robot. So this microscope robot is actually the first in East Africa. So this is changing how people do neurosurgery, how people do spine surgery, and now things like a microsurgery. Microsurgery means operating on very, very tiny vessels that you cannot even see with your eyes. So we do that in CHK, in Rwanda military, in King Faisal. If people say minimal invasive surgery is innovation, yes, it is, because in some ears are quite new, but for me it is not. So we have been doing minimal invasive surgery for the last 10, 15 years. So we...
In Rwanda?
In Rwanda.
And the success?
Yes,
with
a very good success. If people can do that in the abdomen, people now can do upper GI, colorectal using that kind of technology. People can operate in the brain without opening someone's head. So that's what I call developments and probably innovations in this kind of field. But it's huge. If you go to...
Now, no, like you, Professor, let's look at you, like in your field of work. Like, I know when you wake up from home, when you wake up and go to work, you know how your day is usually arranged.
Yeah.
What is this new innovation, new equipment that really is now making your life easy in the theater? Even on breast cancer.
It's a lot, because for me, when you talk to me, like I don't feel it, because you see, I have been the first one in the CHK in my specialty. I had to build it from the scratch. Even when I came, even a simple forceps was not there. So if I start now listing all the new things which comes, I will probably have a list along like
now I understand.
So, but now where we are, that's why people don't know that we are almost there. I'm not saying that we are there. I'm saying we are almost there, because what others are trying to do, we are also at there. So if we can do microsurgery in plastics, so if we can do some craniofacial surgeries, if we can reimplant pieces of bodies, so that's the top. But people think because it is done in Rwanda, it is not the top. It is.
I mean, what would you tell someone who don't trust Rwanda that really? Maybe you can come from UK or somewhere else, where things are expensive. No, like you just talked about breast cancer treatment.
So I'm not even going to do that. I'm not trying to convince people that.
No, it's not convincing people. I'm trying to understand. You talked about trust, that some people tend not to trust their things. what would you tell someone to trust that, by the way, even if you don't trust us, you come and you try
No,
it.
I would just tell them we are as good as them. Yeah, as simple as that. Because we have been in the same classes, and we were not the last of the classes. By the way, we are one of the best. So I don't understand how because I left Paris to Kigali, then when I arrive to Kigali, I will be bad. How?
No, you're not.
I'm still the same. So I'm not becoming probably better, but I still the same. So that quality that people used to see me when I was there, it should be the same quality here, even better. Because here, you know why it is even better here? Because here you have patience, a lot of patience waiting outside there. You can become better quickly
by practicing.
By practicing. So, but you also have that room of innovating and creating your own system. But you have also a very good supporting environment, and people don't. This is not the politics; it's just surgery. But this system is very supporting health-wise. So if you can do what you can do, people are going to support you, and they do it to the maximum of their means. So yes, they cannot give you what they don't have, but whatever they can, they give that.
They'll give it to you.
Yes. So that is a very good kind of political support and political will, looking at how things can be easily developed. So I don't feel that by this move of probably telling people, look, come and you see. No, let's treat our people.
Okay, doctor, what are some of the new, like, if you can, maybe for someone who doesn't know about a lot that has been going on, what are the new specialities that so far in Rwanda that we treat, that were not there maybe 5 years ago? Let's just say 5 years ago.
5 years ago in Rwanda, so
new surgical specialties.
Yes. So now you are coming in my domain. So when we started, so the surgical specialty started in Rwanda in 2005. Just one specialty started at that time. It was what we called general surgery. So in 2012, 5 others have been added. So this is neurosurgery, urology, ENT, orthopedic surgery. So, and then a few years later, around 2000, at that time, maxillofacial and the plastics started in 2018, 2017 as a training program, making them locally. So now, recently, we on top of all those, we added colorectal surgery, vascular surgery, cardiothoracic surgery, transplant surgery, breast surgery, and what is the autologic surgery? You see?
And all of those ones, we have specialists in that.
All of the, not only we have specialists in all that, we have also started training surgeons locally.
Wow.
So that's why I was telling you it will grow like a mushroom. It will be exponential, because now, when it was one training program, it was 20 years ago. Now, 20 years later, we have 15 programs training. So if a program can probably make 10 surgeons a year, now 15 are going to make 150.
A year?
Yes. Yeah. Now in surgery, I have 141 trainees.
You have now 141
trainees
that you're training?
That are being trained.
To become surgeons?
Yes. In all those specialties I'm citing.
Oh, so probably this year we're likely to have...
So if now they will, in those 141, they are not all in the first year, and they are not all in the last year. So probably what is sure, 5 years from now, all these people will have been graduated. So it means if we can use them as a training pool. It means, imagine if
in another 5 years, they will also produce times 2 of this.
No, or maybe times 10, because one of them is going to be taking 5, 10 students.
Wow.
So that's
Strategy is really nice.
That's how it is going to grow, and that's now the issue is going to see is now the workforce enough? Because people get that sense that if you produce people, it will be enough. It will not be.
Because the population is also increasing.
Even that, because the surgery, you don't operate in each room you see. You don't enter here and start operating. You need to create, proportionally to this number, the number of theaters. You have to equip them. You have to have as good and as many as anesthesiologists, because these people will not be operating when patients are awake. You need to have as many as the numbers of nurses to make sure that all these theaters are going to function.
Trained nurses
So yes,
on each specific specialty actually.
so then it becomes an ecosystem. So you have to think beyond just the
number of
numbers,
human resource.
the number of human resources.
I mean, of specialists, sorry.
Yeah, you have to be bigger than that.
So, to a young man, a young woman out there, a young lady who wishes to become a surgeon and would want to hear a very, promising and, an advice from a senior surgeon like you, what would it be? What would you tell such a young man? Like even those ones you're training right now.
Yeah,
that maybe you don't say in class.
No, I try to do that. As I remember recently, I had to organize a meeting with all these 141 outside the classrooms and outside the hospitals to discuss that, by the way. How do we inspire the next generation? How can attract people in what we do? And one of the advice I will tell them that surgery is a rewarding profession. It's rewarding in a multiple aspect of it. So it's rewarding because you feel and you see the result of what you see, you do. So if you operate on someone, tomorrow is doing well or not, but the majority of the cases it is doing very well. So you see the result quite very easily. But also you feel that you serve a bigger purpose. You are contributing to save lives, to improve the people's well-being. But even beyond that, you are not in. It's a rewarding also socially. Socially, you are a little bit respected, but you also the take home is not bad. So you can get what you need. Your family will not live in need if you are a surgeon. So all that together, I find that if I have to choose again,
you would still choose the job you're doing now.
Yes, I will still do surgery.
Wow. Where do you see Rwanda in 10 years in the health sector?
In health sector, I feel that we will be very far. We will be very far. I found that we will be really a center of excellence in this region, because if I see what is happening in nearby countries, I find that we are a very good track. If these things are continued in this momentum and we continue this rhythm, we are going to be very far from now. And that what I call very far is at that level where we will be able to provide all the surgical services that one may need here. So, and we have also serving the nearby countries, serving like an attraction that people are going to come and seek surgery here. I remember in that discussion I was having with my colleagues, my students, I told them, which surgeon do you know in India? All of them told me, no one. Then I told them, okay, if you don't know any surgeon, why do people go there to get surgery?
They trust the system.
They trust the system. And that is the most important piece of this business. It's not about me as a Faustin or someone else. It's all about this system. We should make sure that this system is trustable. And even if you see someone trying to undermine this and that, stop him.
Doctor, you were telling me about that. Some people even go and find themselves not knowing any hospital they're going to visit. and not knowing any surgeon, and at the end they land into thugs or people who will pretend to be surgeons, the best one they wish to have, yet they are not the one.
Yes, and that's a really a very bad experience. But unfortunately, it happens, and because people don't have necessarily the trust they should be having in the system here. But it's our job and responsibility to build that trust by doing well what we're supposed to be doing, not necessarily by being on the air and telling people we are doing well.
Come on, but
Come,
doing
yes.
the best.
Yes, doing
and
the
so that
best.
people who have visited the hospital can give the testimony of what they found there. So, as we conclude, what is it that you would wish someone to hear from you that when coming to this podcast you expected to share with the public that I've not talked about?
We covered a lot, but I do think that we have to summarize, telling people that surgery in Rwanda is coming from far. So as all the other services, it has to be started from the scratch after the genocide against Tutsi. But we are progressing well. So all of the issues have not yet been sorted. We're still having a few improvement things that we should do. But the beauty is that we know where we are going. And when you know the direction and you have a good vision, so it's a matter of time to arrive where you are heading. So we are able to do much more of maybe 60-70% of all surgical procedures can be done here in Rwanda. Or we're still having a 30% gap in terms of vertical growth. So when I say vertical, it means in terms of complexity, from the least complex to the most complex surgical procedure. We're probably somewhere at 7 to 10. In terms of this is like vertical and horizontal growth. So in terms of numbers now, so that's where we should be really doing a lot of efforts. We are around 50%. So those people who are needing to be operated on time and get the right procedure where they need it, we're still having issues in terms of workforce and that accessibility, because that's why our waiting list is quite still long. You can be easily given an appointment to be operated 1-2 years later because of the numbers. So, but the numbers is not an issue for me, because what my worrying me more is if we cannot do going up, but if just we need to multiply people, that is the easiest part of this. So we are having a very good track, and we are being very good supported. So now I'm encouraging the next generation of general practitioners, young ladies and men, and actually I'm encouraging ladies to join the surgery, because I find that our women are still thinking that surgery is a profession for men. So, but I just tell them that women do better than men in surgery. So we need them, and if they can join, we will be happy. So now that the IT and the technology is increasing in surgery, they will even fit better than what we used to be doing in the traditional surgery. So that's what I can say. So, and I just want to thank you for hosting me tonight for this wonderful discussion. And
wow, that's really wonderful, Professor. We really appreciate your time here. So to our viewers, we appreciate your time, and thank you so much for staying with us. You've seen it. Professor Faustin has discussed a lot about breast cancer, a lot about surgery in Rwanda, a lot about what you should be doing, and not be worried once you may be told that you're going to be operated on. You should not have any fear. Just know that trust your surgeon, trust your doctor, and trust what is going to happen to you, because he has said that the percentage of having of dying inside the theater is actually less than 1%.
No, below 0.1.
It's
So
below
if-
0.1.
Yes.
Wow, that's really a very nice percentage. So I think this was a wake-up call to many people who feel like, no, I should not have the surgery yet. Maybe your doctor has advised that it's the only thing you need to do. So please, watch this conversation. You will learn a lot. And for us, our target is to keep you updated and informed and educated. That's it. See you next time with another guest. Bye for now.